Hello, my name is Lester Willis, and this is a case presentation of bipolar disorder for Brandman University, Class 609 Medical Genetics. Bipolar disorder is a common and severe multifactorial and polygenic condition. Its average age of onset is 25 years old. Lifetime prevalence is 3.9%, 12-month prevalence of 2.6%. Bipolar 1 is the most severe type of this disease, which has a 12-month prevalence of 0.6%. Just over half of those with the condition receive treatment, and of those, there is under half that are receiving minimally adequate treatment. So there are a lot out there who are not receiving treatment and many who are not receiving adequate treatment. There are four main subtypes of the disorder, being bipolar 1, which is your most severe and debilitating, bipolar 2 being less severe in that the manic phases are usually hypomanic and do not cause loss of functioning. Cyclothymic is less extreme mood swings, but they may occur more frequently. And then you have a section or a category for those specified or not otherwise specified, meaning they may be medication induced or induced by a medical condition. In the genetic influence, inheritability is said to be between 60 and 80%. One parent with the disorder is associated with a 15 to 25% increase, or both parents a 50 to 75% increase in risk. The mutations along 290 separate genes across the genome are associated with the disorder. The most studied is the gene CACNA1C. This is a representation of all the possible chromosomes and all of the different genetic variations that happen across all chromosomes. And this is a Punnett square of just one of those genes that's been found to have risk, and the A allele is the allele of risk. And with this Punnett square, it shows there's a 50% chance if one parent has the A allele. Non-genetic factors to the disease include alcohol and substance abuse, physical and sexual abuse. There are medications and medical conditions that can create the condition. Also, if a person lives in a high-income country, they're twice as likely to have risk versus someone who lives in a low-income country. And those who are separated, divorced, or widowed are at greater risk than those who are married or who have never been married. The symptoms depend upon the type of mood that the person is experiencing, or the mood episode, and it can include psychosis. In a manic mood, a person may feel euphoria, have increased energy and activity, a decreased need for sleep, and they may have racing thoughts due to their flight of ideas that is expressed through pressured speech. They might have grandiose beliefs, believing they're high levels of authority, or that they might believe that they are immortal, and they may exhibit reckless behaviors such as spending sprees or increased activities in high-risk sex, and they may be agitated and irritable as well. In a depressive mood episode, a person might feel hopeless, have decreased activity, may sleep more or less, they may eat more or less, they may have experiences where they cannot enjoy what they used to enjoy, may have feelings of emptiness, may also think about death and suicide. And then a mixed mood is a combination of the two. They may be feeling sad but at the same time irritable, and usually mixed moods are a little bit less extreme. And also there's hypomania, which is less extreme than mania, where a person usually doesn't have the grandiosity or the psychotic symptoms. Psychotic symptoms do often occur with manic episodes, usually as delusions or hallucinations. And when they do occur, typical to the manic phase, they're considered mood congruent. But if they happen outside of the manic phase, they're usually considered mood incongruent. Currently, there's not really genetic testing that is done in the clinical setting for bipolar disorder. As we saw earlier, there's so many different genes involved, and the evidence just isn't strong enough to warrant that testing. A person could test for other monogenic disorders that may have similar symptoms, but many of those disorders have other physiological traits or intellectual disabilities that make those diagnoses already readily known. There is some future in some non-genetic protein biomarkers as well as genetic testing if the evidence does become strong enough. But aside from those tests, a person should be ruled out for substances or medications that are inducing the disorder, and also medical conditions should be ruled out. Regarding complications, substance abuse is highly associated, and suicide is also not uncommon. It's believed that as high as 50% of all suicide attempts are by a person affected with bipolar disorder, and maybe as high as 25% of all those that complete suicide. A person may also have difficulties just in their day-to-day tasks, have trouble at work, which can lead to lower socioeconomic status, and a person may experience financial troubles. They may have difficulty with impulse control or violence, which can lead to legal troubles. But functionality can recover, but it is usually slower than the symptoms can be resolved. But a person usually does become fully functional between mood episodes. Treatment includes medications such as mood stabilizers and atypical antipsychotics, sedatives, and antidepressants. Antidepressants have to be used cautiously as they can create a manic phase. Psychotherapy has also been found to be very beneficial. Case presentation: Mr. S. Mr. S is a 54-year-old Caucasian male who resides within a maximum security forensic facility. He is currently functional in this setting in that he can interact appropriately with his peers and with his staff. He completes his ADLs independently and is also active in his treatment. Mr. S was born into a two-parent home, but his parents divorced when he was at age 3. His father was said to have been erratic and had issues with substance abuse. Though he wasn't diagnosed as bipolar, it is believed that he may have been bipolar. His mother remarried, and he was raised by his mother and stepfather with no further contact with his father. His mother is without symptoms of mental illness. He had 2 siblings, a sister who passed away last year due to overdose, and she was diagnosed with bipolar disorder, and a half-sister who is without symptoms of mental illness. Mr. S was married but is now divorced and has 1 child, a daughter who is 17. Neither his ex-wife nor his daughter have had symptoms of mental illness, though his daughter is before the age in which the condition may manifest. And this is a family pedigree of Mr. S, showing those who have had or suspected to have had bipolar disorder in the family, being his father and he and his sister. Regarding social history, he was born in New Jersey, moved to California as a child. The last 2 years of high school were completed in Scotland, Afterwards, he moved back to the States, was a carpenter both in Hawaii and California, before becoming a painter and was self-employed. Uh, he was married and divorced and has a history of alcohol abuse and issues with substance abuse. As far as legal history goes, Mr. S has had quite an extensive history of legal troubles. He was incarcerated in the past for a fairly long list of serious violations. Afterwards, he was hospitalized, released, and he again committed a fairly extensive list of some serious violations, um, was incarcerated, and it is now again hospitalized after those offenses. Mr. S first started having symptoms of bipolar disorder at age 23. He started to become a little disorganized and having a little difficulty with functioning day to day. He then began having manic episodes where he would be euphoric, grandiose, impulsive, have spending sprees, and these would last for a week and sometimes longer, and also depressive episodes where he'd feel sad, isolated, and hopeless, and he would also have some thoughts of suicide. He was required at one point to be on a watch in a county jail where he had had some psychotic symptoms as well, with auditory hallucinations to kill himself. Other psychotic symptoms include paranoid and persecutory delusions and some grandiosity. He is diagnosed with bipolar 1 disorder, with the most recent episode being manic and having psychotic features. Also diagnosed with an alcohol use disorder, an amphetamine type substance use disorder, opioid use disorder, and cocaine use disorder. Regarding his current health status, Mr. S's symptoms of bipolar disorder are currently under control and being managed. He is diagnosed with hepatitis C, which is frequent among inmates and associated with substance abuse and mental illness. Last year, he was diagnosed with hypothyroidism, which is just over 2.5 times more common among those with bipolar disorder. He also has hypertension, as also vitamin D deficiency, which has also been found associated with bipolar disorder. Mr. S is also obese. Of interest, there is a genetic component to the response to atypical medications that has been found that does create that side effect of weight gain from their use. Mr. S's medications include Depakote and lithium as mood stabilizers, and risperidone, which is an antipsychotic for controlling his bipolar disorder, levothyroxine for the hypothyroidism, atenolol for hypertension, and a vitamin D supplement for his vitamin deficiency. Since genetic testing is not currently available in the clinical setting, genetic testing has not been completed for diagnosis of bipolar disorder. He has had urine toxicology as well as other lab tests completed, for ruling out medical conditions and for ongoing monitoring of medical conditions and for drug levels as well. As far as social support, he does have family in the community. His mother does come to visit him and interacts with the treatment team, and the daughter also visits and is involved with interactions with the treatment team and discharge planning. And his mother and daughter are really his most important social support. As far as patient and family knowledge, the mother, the daughter, and the patient are all familiar with bipolar disorder and its treatment. Um, the mother, having been married to a man that was believed to have been bipolar, having a daughter who died from overdose and a son who's incarcerated, she has sought out information about the disorder, and the daughter has learned from her father's experiences and from talking to the treatment team. They would all agree that there is a genetic component, but yet the specific risks aren't necessarily understood. Recommendations for the patient include continuing his medications and seeking support services upon release. He needs to be aware that he must always continue his medications and that he should not participate in activities that include alcohol or substance abuse. A balanced diet and exercise will assist in mitigating weight gain from the medication while also helping with his hypertension. He should also ensure that his psychiatric providers are aware of any medical treatment that he might seek, such as treatment for Hep C, which has been found to induce manic states. For the family, it would be beneficial for additional education regarding genetic risk. It may be helpful to include descriptions of risks as being low, medium, or moderate to high versus trying to assign a specific risk calculation number due to all the variations in risk calculation and as far as comprehending that risk. Methods of early identification and risk mitigation would be beneficial for the daughter, who is not yet at an age where symptoms will have shown if she is affected by the disorder. And psychological support would be helpful for both the mother and daughter. In conclusion, with treatment in the community, collaboration between care providers, and abstinence from substance abuse, Mr. S should find that he is able to function productively, and education and therapy would be beneficial for his family. Thank you so much for taking the opportunity and time to view this presentation.